Well, I think it is really weird experience to me. I'm alone in this such a big podium. I'm the some of the example how we cope with the COVID-19 situations. Even if we have two distinguished speakers and panelists connected through the remote manner, but I feel like some actors in the monologue in this the podium. But well, as previously introduced, we are going to talk about some digital healthcare situation in the hospital perspective in two advanced countries, Denmark and Germany. So it is my privilege to host and moderate this session in Korea and say maybe good morning, maybe 5 hours or 6 hours behind South Korea. So we have two distinguished guests from EU. As a warming up, I'm going to do this session as the fire chat meeting like style. So I'd like to ask the first question to both of you. Would you please introduce yourself and also the brief introduction of your current nationwide or your institutional status of digital healthcare adoption in a real world, in a real clinical world. First, Dr. Brandslund, please.
Yes, hello. In Denmark, the introduction and investigation of value of using AI in clinical medicine and in commercial life is actively promoted and supported economically by the Danish government and state. Recently, the Danish government Department of Digitalization, which has been organized for the purpose, have supported the start of around 20 so-called signature projects at different areas as inspiration for others, but also as a way to investigate what the problems are about digitalization and use of artificial intelligence in clinical medicine. The government has just published the first results, experiences from these signature projects right now only in Denmark, but only in Danish, but you should be able to get the right impression by reading it, and it will be translated to English so others can read it. You can get a link from me if you just email me. On the regional level, in the region of southern Denmark where I work, an innovation working group has been formed with the intention to work on application of artificial intelligence within many areas that are not stated yet, they are not defined yet. On my local hospital, a working group has further been established to initiate new projects, to get ideas about new projects and to start up and complete new projects with artificial intelligence. Two of our local rich commercial companies, the Dandy Chewing Gum Foundation and the Lego company, Kia Capital, has built a commercial park with a focus of artificial intelligence with many buildings to new startup companies working on artificial intelligence together with the public sector. Our local hospitals now in Denmark are totally digitized already, and as such are almost ready to use artificial intelligence, at least in theory, because we have some other experiences I should tell you later. Our vision of technology is that we want to use the highest level of technology available for the purpose of clinical treatment of patients and diagnostics. A roadmap and a policy is right now being worked out, but has not been finished. So that is the situation right now in Denmark as we see it. Maybe I should also say that prescription systems and electronic patient record systems, a totally digitized and robotized laboratory system is working quite fine. But the problem is the connection for use in artificial intelligence.
Okay, thank you very much. How about the Germany situation regarding the whole digital healthcare adoption in hospital situation, Dr. Weigand?
Yeah, well, let me say from an EU perspective, from an European perspective, in Germany, the situation is nearly the same as in Denmark and in other European countries, of course. We have lots of new laws, especially from the EU. For example, the GDPR, the regulation for privacy of data, which we are facing, especially in the use of new technologies like AI. But in Germany, I have to say that digitization, especially in the healthcare sector, is much behind other European countries. We have started right now in the last year with a lot of different new laws which try to get the digitization, especially in the healthcare market, running faster and faster. And first of all, I have to mention the so-called Digitale Versorgungsgesetz, which is a law which now allows, especially in Germany, the first time ever, to have digital applications on prescription. This is very new for Germany, of course, and it's, I think, very new for the whole world, because that's the biggest market you can reach for around about 70 million people directly with a digital application and get reimbursement for this application. That's the, I know, biggest market in telemedicine we have worldwide. Another law, which is called the Krankenhauszukunftsgesetz, which addresses more the hospitals in Germany, spends lots of money now on the digitization on especially hospitals, the interconnection, the networking of hospitals, not only the digitization of processes in the hospitals, but also to provide more digital applications for especially the patients, and of course to do more interconnection here. And with all these laws, we have also the telematic infrastructure be forced in Germany to provide a network for the physicians to connect each other physicians and the patients, and of course to provide an electronic patient record. We have, I think, defined around about in 2006 and never got it. But now it's the time to have it, and the German government tries to push force on that and to get established the telematic infrastructure and the digital health record for Germany. And that's, as I think, a very new thing we have here in Germany, and which rides us much faster to the future.
Okay, thank you. According to the OECD report, actually the Denmark and the South Korea is the two strongest countries to use the new technology in the healthcare situation. For your information, actually the South Korea government has a very strong vision to adopt digital healthcare in the real world. From the technical perspective, the government think that the Internet of Things, cloud, AI, big data, and mobile application are the essential element for facilitating digital healthcare in the real world. And also the government has a lot of project regarding they call that the DNA, the data network and artificial intelligence. So actually we did a lots of project from Ministry of Science and Technology, Ministry of Health and Welfare, and also the Ministry of Industry and Trade. So we successfully implemented some new applications and new artificial intelligence softwares in a real world situation, and even we exported some of them into the other regions such as Middle East or some United States. And through the COVID-19, actually in South Korea, the telemedicine, teleconsultation between physician and the patient directly is not allowed, but due to the threatening raised by the COVID-19, now the South Korea is temporarily allow the telemedicine service to the patients. So that might be one of the big issues in South Korea. So actually, I know that Dr. Weigand in Germany, you have some experience about the telemedicine application in your institution. So would you like to share your experience, how you adopt that kind of service in a real world?
Yeah, well, as I mentioned, we have a new law, the Digitale Versorgungsgesetz, which allows us now to have such kind of digital applications on prescription, which means that it's now possible for healthcare providers to bring in a digital application. This could be a web application, a smartphone-based application, for example, and also, of course, an application which is connected with a wearable, for example, and to provide a service to the patients. So it's a patient-centric service they are funding here. And if this is all true and your product, your application is a medical product, so it's a certification according to the Medical Device Directive, which is a European law, much similar to the FDA, for example. And it's a risk class, which is not very risky, so it means class 1 or class 2, for example, then you could go ahead and register for a so-called digital health application. Abbreviation is a DiGA. And this DiGA then you can bring to the market, and the physicians can directly prescribe their patients these digital health application. Or you go as a patient, you go, for example, directly to your insurance company and say, well, I have this, that indication, and there is an DiGA for me. Could you please prescribe this application to me? And then you can earn money immediately. So if you have the registration in the DiGA directory, then you can earn money from the first time these DiGAs are prescribed. And the price for that is at the moment discussed between the insurance companies directly with the healthcare service providers. So it's possible that you have a real price, which is an amount of money which is sufficient to go to provide this application, and of course to earn money with that. And to go there, of course, you should also provide to the government that your application helps the patient. So it's called the positive care effect. It's a new definition which such an DiGA has to fulfill. And therefore, you need perhaps some studies to show to the government that your application helps patients, or of course helps to do some structural things which are better than the standard care. So if you can show that you either meet the patient's perspective or the economic perspective, then you are able to earn money with these.
Yeah, I totally agree. I will get back to you after I ask another question to Dr. Brandslund. Actually, the South Korean government funded a very big, project for the AI adoption in healthcare. The situation for past 4 years, the Doctor Answer Season 1, they finished that project very successfully for 8 diseases and 22 softwares for, prediction and also diagnosis and also the therapeutic intervention in some area. Now they are launching the Dr. Answer Season 2, expanding to 12 other diseases and mainly at least, the 30 something the softwares. In Denmark, actually, I think that you also have that kind of similar situation or some government flagship project for the AI aligned with the hospital. So do you have any kind of experience or some memorable project that you are involved in your hospital situation or some nationwide project? Do you have any kind of things to comment on that area?
Oh, yes. In a way, I can tell you that we have worked with digital health since 89 here in our hospital and area and regions. And and also developed robotization and digitization in the laboratories. Our laboratories are totally robotized, and no one touches the blood sample tube from venipuncture to reporting of results and incineration of the blood sample tube. We have also developed telemedicine solutions for patients on anticoagulation, diabetes, and chronic lung diseases, and now on cardiac disease as well. And that work is actually developing rapidly at the moment. This has been described in the larger American journals if you want to read it. Alongside, we have developed algorithms supporting the clinical doctor in governing the patients and monitoring the patients correctly, which has led to my hospital being rated the best hospital in Denmark for the last 12 years, the best in diabetes treatment, and the best cancer hospital in Denmark. And this is just to tell you that it actually improves quality in healthcare to work with digitization and artificial intelligence. Right now, we have purchased the SAS Institute's artificial intelligence system, VIA, and they are doing that in other regions as well and in other hospitals, and are transferring all our digitized data from electronic records, drug prescription records, and laboratory data systems to this platform to work on artificial intelligence in early detection of cancer in the general practitioner's office, better care of emergency received patients, and during the last year, also with risk assessment and choice of medical treatment for COVID-19 patients. We plan to expand the application of artificial intelligence to cardiology and further to oncology in a broader sense, which you will hear in my presentation at around in a couple of hours, actually. Maybe I should also add that we have a very big difference between Germany and Denmark, because we don't have any money or economies between patient hospitals, general practitioners at all. So everything except drug prescriptions are totally free, and drugs are heavily supported by the system, but no payment between parties, patients, and providers. So a lot of things is happening right now, actually. There are other projects in Denmark. It's around 20 bigger projects working in different parts of the clinical areas, but I can't go through all of them. But you can read that in a publication from the Danish Digitalization Institute. And I have sent you that link, but everybody can get it.
Okay, thank you very much. Actually, both the lecturers have their own independent lecture at the later session. So if any audience who is interested in some more details about their work, actually please attend the session, the lectures, which is delivered maybe 3 or 4 hours later, maybe. So I'd like to ask the last question both to you. Sometimes we feel that, we feel some gaps between technology and also the real world, the hospital side adoption. So what do you think is the most important role of the hospital to make some realization to use the digital techniques in the clinical practice, in daily practice setting? Dr. Brandslund first.
Yes, the biggest problem actually right now, I don't think, is the European Union legislation activities, because they can be won and conquered and actually applied. It's not our problem. The technology in itself is cheap, so the prices do not represent a challenge. However, one big problem we have seen in our recent big projects is that all other digital and electronic systems containing data has not been built with the purpose to use AI. So there is a big problem in getting the data out of these databases in the hospitals and the general practitioners in the correct and uniform way, as they have not been organized to that purpose. Further, the systems are not interconnected to create a comprehensive data platform to enable the use of AI for data mining without having a lot of problems with standardization and lack of standardization. To overcome this, a uniform language of the data you want to process in an AI system should be in a form of an international standard. I think some should work on that actually and try to conquer these hurdles. Even a simple measurement of blood pressure presents problems from electronic health record systems simply because they are registered in different ways. Further, as we work right now, we are retracting data from other databases to collect them on the AI platform. But AI is proven to be beneficial. But if AI is proven to be beneficial, these data should flow automatically from the primary registration site and platform to the artificial platform. And this means that the many databases and registers should be changed to enable this. That is our biggest problem in the hospitals, in cooperation with others, and especially the patients and the general practitioners. In our work, we have shown that AI works, and we have checked the reliability by using logistic regression analysis. So AI in itself seems to be reliable, a reliable way of testing information and exploiting value from the information data. However, the information data have shortcomings, and when artificial intelligence is unable to deliver the expected value addition we want, the AI could be blamed on an unjustified basis, as the real problem is that we don't have very good and reliable data. So that is the main problem, to expand from the hospitals, for the hospitals to be the driver, the mover of application of this new technology in better healthcare. But we are working on it, I can tell you.
Yeah, actually, you touched most of the important areas. How about the Dr. Weigand opinions to the same question?
Well, all in all, I have to agree to Professor Brandslund, because I think from a technology perspective, there's everything already doable. But from the perspective of law and politics, we have, especially in Germany, as I mentioned already, big hurdles to get these technologies into the market, into the hospitals. For example, at the moment, from an EU basis, we have with the GDPR, the privacy preserving law, which prevents us to get access to the databases at hospitals, for example. There are huge data lakes with data which is unused and not usable, because we have no way to get access to this data. And if you especially look on technologies like AI, there is no better algorithm than having more data. So there are strong needs to have lots and tons of data to train AI and to get good algorithms. But we are unable to address this because there are our data lakes are more closed, and we do have need access to these data lakes. From the politics we have at the moment, especially in Germany again, that the government says, well, they want to have in the future that every data which is measured at any patient in Germany should become available for research. And that could be a big game changer, especially in using technologies like AI. But let me say one last word on especially AI. In the past, we had algorithms which are calculating different things on people and finding cancer, or for example, prognosing that a patient becomes ill or something like that. This was always understandable and seeable, very clear how this comes together and how the algorithms are working. With AI, we have tons of data which we are training the AI algorithms, and afterwards we are running AI and do not know how AI gets to the result which it is presenting to us. So we have here, especially in the health or in the medical area, the need for, we call it explainable AI, so that we can see how the diagnosis, for example, was made with these algorithms, and to trust these algorithms that they are doing the right diagnosis, for example. And that's a big thing we are talking not only in Germany, but I think worldwide or EU-wide, how we can have explainable AI to trust AI, because the worst thing we can have is that people do not trust what the computer says.
Okay, thank you. Actually, we have some 10 question list. Most of them you already answered to the questions from audience. I'd like to ask you to allow me to speak in Korea just 1 or 2 minutes for the Q&A session for audiences, please. 질문을 한 10개 정도 올리셨는데 그 중에 한 절반 이상은 지금 이 패널리스트들이 대답하는 과정에서 어느 정도 대답이 됐다고 생각하고요. 하나 정도만 하고 세션 마무리하겠습니다. 시간 관계가 있어서 마지막에 고성환님께서 이제 비대면 진료가 앞으로 가능하다고 하는데 비대면 진료가 AI하고 컴바인이 되면 그게 얼마나 정확할 거냐에 대한 문제와 그렇게 되면 의료인들이 많이 필요 없어지지 않을까 이런 걱정을 하셨는데 사실은 비대면 진료에 관련해서는 앞에서도 이 패널들도 말씀하셨는데 이게 비대면 진료가 디스커넥션 되고 그 데이터가 앞에 세션에서도 나왔던 얘기인데 데이터로서 작동을 하지 못하면 사실 이게 계속해서 서스테이너블하게 발전하기 어려울 수도 있다라고 생각을 합니다. 그래서 이게 기존에 이제 데이터라는 관점에서는 이 데이터의 연속성을 보장하는 상태로 비대면 진료가 테크니컬하게 발전을 해야 되고 물론 마지막에 AI가 들어올 수도 있는데 그렇다고 해도 저희가 항상 AI에 관련해서 말하지만 AI가 이 메디컬 엑스퍼트의 대체제가 아니라 보완제로서 쓰일 거다라는 그 개념을 아직까지는 가지고 있고 꽤 오랜 시간 동안 그게 이제 기존의 의료 인력이나 그 널리지를 대체하지는 못할 거다라고 생각을 합니다. 병원의 입장에서는. 그래서 그 정도 말씀을 드리는 게 제일 좋을 것 같고요. 아까도 말씀드렸지만 두 분 연자분이 뒤쪽 세션에서 각각 따로따로 준비하신 슬라이드로 프레젠테이션을 하도록 되어 있습니다. 그래서 조금 더 궁금하신 거 실제 프로젝트에 대해서 물어보신 질문도 있었는데 그 부분은 세션 뒤에 좀 강의를 들어주시면 감사하겠습니다. Okay, I think we have to wrap up this session. First of all, thank you for your valuable time and attending this meeting, even if it is remotely. So next time, I really hope to see you in EU or in Seoul face to face to talk about some more deep discussions about digital healthcare between EU and South Korea. Thank you for your cooperation. Thank you.
Thank you. Thank you so much and goodbye. See you in a couple of hours.
Thank you very much. It was a pleasure for me. Bye-bye.
Bye-bye.